Welcome to the John F. Kennedy Forum and tonight's discussion entitled Women's Health, McCain versus Obama. My name is Dr. Paula Johnson, and I'm the Executive Director of the Connors Center for Women's Health and Gender Biology and Chief of the Division of Women's Health at Brigham and Women's Hospital. And tonight you will hear how each campaign is addressing some of the most important issues in women's health. Women make up over half of the population and have consistently cited health care as a top issue in the presidential campaign. For many women, health care is an economic issue. The slowing economy and concern about health care are absolutely inextricably linked. It's also true that women are often disproportionately affected by our health care system. Women consume more health services across the lifespan, spend more each year on health care than men, and pay more of their health care costs out of pocket. Women live longer than men. They're more likely to have multiple chronic conditions such as diabetes, heart disease, and arthritis, and are more likely not only to be the care providers, but are also more likely to need long-term care. Not only do women have unique reproductive health needs, but today we know that women and men develop disease and respond to treatment differently, and we are only at the very beginning of understanding what those differences fully are. So the issues we're going to discuss tonight will include affordability of insurance, the range of benefits covered, as well as reproductive health. But we also hope to touch on some of the issues that are not as commonly addressed that can be critically important to the health of women, such as provider shortages, long-term care, and chronic disease and prevention. The purpose of this evening is to learn from our panelists, to raise issues, and to stimulate respectful discussion. You'll hear from Dr. Alina Salganikoff, Vice President and Director of Women's Health Policy for the Kaiser Family Foundation, who will lay the groundwork by discussing some of the important healthcare issues that women face. We'll then have a moderated discussion with Drs. Gail Walensky and David Blumenthal. Dr. Walensky, at the end, is an international health is a senior fellow, is an economist and a senior fellow at Project Hope, an International Health Education Foundation, and she is a senior healthcare advisor to Senator John McCain. Dr. Blumenthal is the director of the Institute for Health Policy at Massachusetts General Hospital and is the Samuel O. Thier Professor of Medicine and Professor of Healthcare Policy at Harvard Medical School. Dr. Blumenthal is a senior healthcare policy advisor to Senator Barack Obama, and I think we know who Dr. Blumenthal is. Our discussion will be moderated by Sheila Burke, who has had a distinguished career both in public service and here at the Harvard Kennedy School of Government. She is currently a faculty member at the Kennedy School and a faculty research fellow at the Malcolm Weiner Center for Social Policy. Before we start our program, I'd just like to recognize this evening's co-sponsors, the Malcolm Weiner Center for Social Policy and its director, Julie Wilson, who's with us this evening, the Institute of Politics and its director, Bill Purcell, the Kennedy School's Women in Public Policy program, as well as its Health Policy Professional Interest Council, and the Connors Center for Women's Health and Gender Biology at Brigham and Women's Hospital. And lastly, there are 4 people that I'd really like to thank for working so hard to organize this evening on a very short timeline. Barbara Whalen, the Executive Director of the Malcolm Weiner Center for Social Policy, Tracy Hyams, the Director of Women's Health Policy at the Connors Center, Dr. Alina Salganikoff, who I've already introduced, and Usha Ranji, who is the Principal Policy Analyst for Women's Health at the Kaiser Foundation. So let's get started with Dr. Salganikoff.
Good evening. It's a real pleasure to be here tonight. Hopefully the technology will all work there, the slides, great. We have heard a lot from the candidates and the campaigns over the last 2 years about a lot of issues, and now we're really narrowing into the final stretch. We've heard a lot about health care, and certainly women have been front and center on this election, but we really haven't heard very much about the intersection of health and women's health. So tonight we'd like to take an opportunity to really explore this issue with the different candidates' representatives. What I'd like to do in the next 10 minutes is a quick 101 on women's health, but really looking at the policy issues, coverage, access, and the delivery system. So I usually do this talk in like 45 minutes, so bear with me. The first slide is actually data that came out just this week from the Kaiser Family Foundation. And it really looks at the experiences of women and men in terms of the impact of costs on coverage and access. And I have to tell you that this data really surprised me. You see, and there's a brief out there that has the data from April. So now fully 40% of women said that because of cost they postponed or went without care that they needed. 36% said that they skipped a recommended needed care or a test or treatment. Looking at prescription drugs, you see 32% of women didn't fill a prescription, 26% said that they cut pills or skipped doses of medicine because of cost. These numbers are between 5 and 10% higher than what we saw in April. I was showing them to Sheila earlier, and it's very dramatic. So I don't know whether it's because of the fact that the economy has, people have lost their jobs, or the sense of insecurity that people have and some behaviors that they're changing, and there's been some press coverage around this issue. We also know that worker costs for premiums have been rising at very rapid rates over the past decades. From 1999 to 2008, employee premiums more than doubled, rising from around $1,500 a year to families paying now over $3,300 a year. So those are also dramatic increases. In addition to costs, coverage has really been a central issue of this campaign. So this shows here the profile between the differences between men and women. And you can see here in blue that most non-elderly, these are women between 18 and 64, get their coverage through their employers. And although men and women are equally likely to have employer-sponsored coverage, about 2/3 of them have this coverage, women are more likely to be covered as dependents, and men are much more likely to have coverage in their own name. This is because a sizable share of women work part-time or part-year, or they work in low-wage jobs that really don't offer benefits, and so they end up getting covered through their spouse. Having dependent coverage can really make women much more vulnerable to losing their insurance coverage, should they become widowed or should they become divorced. And with the rapid growth now in costs, women are increasingly becoming vulnerable to losing costs if families are unable to shoulder the costs of family coverage for workers. A small share of men and women, about 6%, are covered through the individual market, and these are people who purchase insurance on their own. Now, it's important to note that women are less likely to be uninsured than men. Some people actually think it's the other way around, but the reason for that is because of Medicaid. Women are much more likely to qualify for Medicaid than men, and that's because women are A, more likely to be low income, and also to fit into the categorical requirements that the program has, which is to be the mother of a dependent child or to be pregnant, men don't fit that one, or to be disabled. Now, we've been hearing a lot about expanding coverage, but I do think it's instructive to take a minute to really look at the issues of public and private coverage, because these plans and programs can also fall short for women. So as we're looking at designing new systems, it's important to take a close look. In terms of employer-sponsored coverage, as I mentioned earlier, the affordability issues are really mounting. But another issue that hasn't gotten as much attention is the scope of coverage, as there is considerable variation from plan to plan and also from state to state in terms of what they require for these plans. And in addition, there have been tremendous growth in the high deductible health plans. So a lot of women are now in plans that have deductibles $2,000, $3,000, $4,000. So really, a lot of the payments are for them up front. In the individual market as well, there are some major challenges. Pre-existing exclusions disqualify many women with chronic conditions, and in most states, or make their coverage unaffordable. The scope of coverage is also typically more limited in individual plans. And in addition, there is gender rating, where women are charged more for premiums than men of the same age. And this is a case in 40 states. And last but not least is Medicaid. You might not know this, but 3/4 of adult Medicaid beneficiaries are women. As I mentioned earlier, this is because of the income and the categorical test. But there's considerable churning on and off the program and instability, as even minor changes in family income or family structure force women to requalify for the program. And finally, Medicaid pays providers very low rates. So in many areas, it is very difficult to find a provider that's willing to serve women. So these are some just issues around coverage that we're going to need to consider. And then the other issue is really, how do we help the 17 million, the 47 million uninsured? In thinking about a program to craft this group, I think it's important to consider that these are women who are in households where there at least is one full-time worker. In addition, many uninsured women work in part-time jobs, or they work for low-wage jobs and don't have access to benefits such as health insurance or sick leave, for that matter. These are women who are disproportionately young, who are low income, women of color. 1/3 of Latinas are uninsured in this country. And there is a large body of research that really has shown over and over that the uninsured have poorer access, lower use of preventive services, less likely to get treatment, and have poorer health outcomes and greater mortality. In addition to coverage, the healthcare delivery system also shapes how women use healthcare services. As I mentioned earlier, chronic illnesses are a serious concern for many women. As you can see here, a surprisingly large share of women, if you look, 1/4 of even younger women, face a chronic health problem that requires ongoing treatment. Many of these conditions can be effectively managed with basic primary care. Yet we face a national shortage of a primary care workforce in the nation. On average, 43% of women in the country live in an area with a shortage of primary care professionals. We also have half of U.S. counties that lack a practicing OBGYN, and there is a major shortfall of abortion providers in the nation. And in some areas, a real dearth of mammography equipment and radiologists to read the mammograms. This is just one aspect of the delivery system. We have major concerns and need to improve areas of health information technology, quality of care, health literacy, cultural competence, just a few of the areas that we really need to focus on. As we turn to reproductive health policy, there are also a number of challenges. In the United States, over half of the pregnancies are unintended. Half of these pregnancies end up in abortions. Women with unintended pregnancies are more likely to have complicated pregnancies and poor birth outcomes. There is also a sizable disparity in unintended pregnancy rates, with higher rates seen among women of color and poorer women. We have also seen in the past year a slight uptick in the teen birth rate. And so though the data aren't out on teen pregnancy rates or abortion rates, it's going to be interesting to see whether that continues as well. Another major issue that's gotten quite a bit of press is the high STD rates in the nation. We're finding that young people are increasingly at risk. Infections like chlamydia are dangerously high for young women, and HIV and AIDS continues to take a devastating toll on communities of color and women of color. Another issue that we really need to consider and address is the rising C-section rate. Today, over 1/3 of births in the United States are C-sections, which is, I believe, among the highest rate in the world. And this can clearly have serious consequences for health, has implication for costs, and recently some information has come out in terms of even women's ability to qualify for health insurance in the individual market. Education, particularly sex education, has been a flashpoint at the federal and state level, with increasing numbers of states now that are walking away from federal funds that require abstinence-only education in light of concerns of the rising birth rates and higher rates of STDs. And finally, the abortion debate. There are Supreme Court appointments at stake, federal and state policies, all have the shadow of abortion is in all of those discussions of reproductive health. One of the advances has really been shown to effectively reduce unintended pregnancy has been contraception, but the cost and coverage issues are still areas that many women struggle with. We have made great strides in expanding contraceptive coverage in the employer market, where now nearly all plans cover FDA-approved contraceptives, mostly thanks to state mandates, federal court rulings, and I would say Viagra. In the individual market, the scope of coverage is less comprehensive, as the states which do regulate insurance do not have jurisdiction over the individual market to the same extent. And since it's not a work-related benefit, the federal EEOC doesn't really have jurisdiction over this area as well, so we don't have as good coverage. There are also important federal and state family planning programs for low-income women, and this is often their only source of care. Title X provides block grants to agencies that fund family planning services to low-income women and teens. The Title X money has not increased significantly and has not kept up with inflation over the past decade. A lot of the clinics that are serving these women are really finding themselves completely limited in terms of their ability to serve the populations. We've also seen a tremendous growth in the role of Medicaid in providing family planning services to low-income women. There are waiver programs where women don't qualify for full Medicaid, but that are assisted in terms of their ability to access family planning services. Now moving to the other end of the life spectrum, we look at long-term care. And in my opinion, this is a vastly under-recognized women's health issue. Many older women have conditions and life situations that really predispose them to needing long-term care. Women are more likely than men to have limitations in activities of daily living. These are limitations in basic functions such as eating, dressing, walking, transferring from a bed to a chair, getting in and out of a chair. They're also more likely to have limitations in instrumental activities of daily living. Shopping, managing money, using the telephone, these are all things that women need assistance with at greater rates than men. Higher share of women also have cognitive impairments. But we see on the other side the other vulnerabilities that women face. Fully half of women over 65 live on household incomes of under $20,000 a year. Nearly 40% live alone, 46% are widowed. You can see the striking contrast there between men, where 14% of them are widowed. This is because of the women live longer, they're also much more likely to be the caregivers of their husbands and their parents as well. And women are much more likely to live longer, be over 85, where they are really much more likely to be frail. And not surprisingly, we see that older women populate our nursing homes and keep home health aides employed. According to the HHS, a year in a nursing home averaged $77,000. Home health aides cost an average of $29 an hour. Who pays for this? Well, half of long-term care is paid for by Medicaid, but this assistance goes to the poorest women, those whose medical or long-term care expenses have forced them basically into poverty because they've been so overwhelmed. Medicare pays for these services only after a hospital discharge, not for a prolonged stay, let's say for someone who expects to face chronic deterioration like an Alzheimer's patient. A sizable share of women and families bear this cost on their own. While a few have long-term care policies, most do not, and public or private options to address these major health needs are very limited and can be very expensive. So in closing, we've seen the uninsured and costs as key issues in this campaign, but the scope of coverage is also an important issue that we'll need to consider. We also see that the healthcare delivery system needs to be shored up to meet the needs of women in terms of technology, supply, and quality. And finally, there are key issues that cut across the lifespans of women that are at the heart of many of the discussions at the federal and at the state level. I'm looking forward to a good discussion tonight on many of these issues with our campaign representatives. I'm going to turn it over to Sheila Burke. Thank you.
Thank you, Alina. We, I think, have gotten a good overview of the kinds of issues that we are going to try and focus on this evening. Healthcare is near and dear to all of our hearts, and while the economy and the war in Iraq have clearly filled the sort of coffers of issues that people care deeply about, healthcare remains in the top 2 or 3 issues about which people care, and particularly about women care. in terms of the issues they want our presidential candidates to talk about. Women are, as Alina has pointed out, most often they are patients frequently. They are often caregivers, whether it's to dependent parents or to their own children or to their spouses. They are the purchasers of care most frequently, the people in their homes that coordinate the services that are needed by their families. And they live longer, they use more services, and frequently have limited coverage and are confronting a series of issues that are radically different than the men and their families. The next administration will clearly have the moral responsibility to essentially look and take on these issues and help us navigate what best to do in terms of our healthcare delivery system. Tonight we will have the opportunity to hear from two representatives of those candidates who will talk with us about their plans and talk about how they will specifically address these kinds of issues. I'm going to ask them to begin with the basics, to give us a very brief, very brief overview of the main components of their proposals, and then we'll get into the details. So let me, if I might, begin with Gail. Gail, tell us about Senator McCain's proposal. We know that 1 in 5 women are uninsured. Many of them are low income and working families. Many of them lack access to employer-based coverage and are confronting an issue in terms of going into the market.
Fine. Took off my watch so I can make sure I stay with the brief part of your request. What Senator McCain has done is to lay out a series of strategies that go after the main issues he thinks needs to be addressed if we are to make sure that we have both affordable health care and accessible health care for people in the United States. Let me start with the affordability and cost issue. Right now, as women particularly are keenly aware, but as people in general understand, people who are below the age of 65 primarily get health care through two different kinds of strategies. Either they're on a public program, Medicaid or the Children's Health Insurance Program, or the vast majority of us receive health care as part of our compensation package through our employers. For years, economists like myself have commented on our way of subsidizing employer-sponsored insurance is just plain unfair and also leads to a lot of distortions as well, because the subsidy comes not from the employer providing you with a contribution. That's the employee's compensation package, just split between wages and a fringe benefit, but because you don't have to count that employer contribution of your compensation as part of your taxable income. And that's been the main tax subsidy that people have received. Unfortunately, most people have very little understanding of what their employer's contribution is, even though it's a significant part of their compensation package. And the subsidy that they receive increases the higher their income. So if you don't pay income tax, you don't gain any benefit. If you're in the 35% tax rate, currently the highest tax bracket, it's 35% of whatever that employer contribution is. Could be as much as $3,500 sheltered if you had a $10,000 employer contribution. So instead of doing that, Senator McCain has proposed that everyone receive a sizable credit, $5,000 if you're a family, $2,500 if you're an individual. And that is money that you would use to pay any increased tax that you might owe on this, and to put any additional monies, which would be the case under all but the most extraordinary circumstances, into a health savings account. But it's not just making it accessible in the sense of having everyone be able to receive a credit, because it's a refundable credit, whether or not you pay income taxes, whether or not your employer offers health insurance coverage, but to engage in a variety of strategies to put pressure, downward pressure, on healthcare costs as well. We have an unsustainable healthcare spending growth rate in this country, a couple of percentage points faster than the economy over the last 45 years, in addition to spending in absolute terms a lot per person. And so as important as it is to make sure that the subsidy is not just tied to the vagaries of whether your employer offers coverage, it's equally important to do something to put downward pressure. And there are two main strategies. One is to open up insurance to people so that they can purchase insurance wherever in the country they wish to do so. This is important because in many places, the insurance availability is extremely limited. My work in Maryland, it's basically dominated by two healthcare plans. Many places, the Blues plan, whatever it is, almost totally dominates the market. By being able to go wherever you wish to in terms of purchasing insurance, there will be a lot more pressure on having more efficient administrative practices, lowering overhead and other costs, and being more responsive to what people are looking for. But that also is not sufficient. We all know that there needs to be more emphasis on chronic disease treatment. That's where most of the spending is, disease management, prevention, making information on value and price more available, having more research go into comparative effectiveness, reforming how we reimburse under Medicare particularly, but Medicaid as well, and a whole series of changes that are more directed to the delivery system. A final issue has to do with an area that's been raised by people who are concerned if you have somebody with a pre-existing condition, that they might find themselves unable to purchase insurance or only insurance at very high rates. People need to understand, first of course, that all of the existing laws of the land will continue. HIPAA, which does not allow pre-existing condition exclusions for people in groups of twos or more who maintain coverage will continue, and many states have the comparable legislation even below groups of two. But for people who can't receive insurance coverage or who can only receive insurance coverage at very high rates, the senators proposed what is called a guaranteed access plan. States, either individually or pooling together, will need to offer plans for predictably high-cost individuals that focus on the treatment of people with predictably high spending, using disease management and other strategies, and offering subsidies for individuals that are accessing these guaranteed access plans with special help for those who are low income. So that's the broad stroke of what is being provided, but I'm sure over the course of the next hour or so we'll get into a lot of these other issues.
Gail, I do want to come back when we have a moment and talk a little bit about the individual market and what happens in terms of the breakdown of the group, and a little bit about the pre-existing condition and the guaranteed access. But David, please, an overview.
Thank you, Sheila. It's a pleasure to be here. It's not often that I get a chance to bring diversity to a panel. But in a lifetime, lots of different things happen. So it's also a pleasure to be here with Gail and Sheila, who I've known for so many years and respect so much. The Obama plan has, like the McCain plan in broad outlines, has two major foci. The first is to improve coverage of insurance, and Senator Obama is committed to making certain that every American has health insurance. And that's an upfront, clear, and unalterable commitment. As you heard, if those of you who watched the town hall debate, when Senator Obama said that health care is a right, not a responsibility for Americans. And he would do that in a variety of ways. He believes in a shared responsibility for coverage. He does believe that the employer-sponsored approach to insurance, while having some of the disadvantages that Gail mentioned, is still a politically acceptable and functional way in this country to pool risks, to bring people together, to assure that the wealthy and the healthy are available to subsidize the care of the less wealthy and the less healthy. So the 160 million Americans that currently depend on employer-sponsored insurance are going to be protected in their insurance under an Obama plan. He would then make available affordable individual coverage and small group coverage through reforming the small group and individual market by creating a national insurance exchange. It might take different forms in different regions, but through assuring that there is a regulated and managed marketplace in which individuals and small groups can get access to care that is as comprehensive and as efficiently administered as has been true of the large group market. He would mandate, and this is, I think, an important issue for women, he would mandate the coverage of children. And he would require that children be allowed to stay on their parents' policies until the age of 25. He would expand Medicaid and expand the Children's Health Insurance Program. Medicaid, of course, as Alina suggested, a critical part of the safety net for women, and also a critical source of long-term care coverage in our society. Not a perfect one, but it's what we have. So those are some of the coverage extensions. Of course, the regulation of the small group market and the small individual and small group market that he proposes would require, on a national basis, a guaranteed issue, guaranteed renewability. That is not a feature of the current small group market and needs to be in the future, especially for women who, in tight fiscal times, may lose insurance as dependents as employers seek to constrain spending. On the affordability side, which is another key component of the Obama plan, one of the key aspects of affordability is reducing administrative expenses in the small group and individual markets. And that, of course, would be a feature of the National Insurance Exchange by enabling insurers to compete for the business of groups that would form within that insurance exchange. So that's one key component of affordability. But there are many other delivery system reforms that are critical. I think one of the most distinctive for the Obama plan is his commitment to providing adequate funds to create a national health information network, $50 billion over 5 years, to get us into the 21st century in the information age. That is a foundational aspect for a coordinated, a high quality, a high value healthcare system. Not sufficient for that, but absolutely essential to achieve that. He's committed to augmenting primary care. It's clear that the larger the concentration of primary care physicians, and I say this with full disclosure as a primary care physician, the larger the proportion of physicians who are primary care physicians in any region, the lower the costs of care. And he's committed to enhancing the supply of primary care. He's also committed to enhancing the supply of workers who provide care to the older population in our country. He's committed to improving disease management and care coordination. One of the critical aspects of a national insurance exchange is that by creating a market that private insurers wish to participate in, it's possible to incent insurers to provide care coordination and disease management services for their employed populations as well as for their the populations that are directly insured in those markets. So those are a few of the provisions. There are obviously many other details that we could go into, but Senator Obama is committed to universal coverage and to affordable care through both improved efficiency and system reforms.
Good. Gail, let's go back, if we can, to just a moment with respect to the movement away from employment-based insurance as we understand it today to more of an individual market, potentially. And the question as to whether or not that is likely to put at risk women who are entering into that insurance market who may have pre-existing conditions, chronic conditions that can either disqualify them from coverage or make the monthly premiums so costly they can't afford them. How would Senator McCain deal with that issue?
Well, the first is I'm going to challenge your basic assumption because I truly do not believe it. I don't believe it as an economist. Even some of the numbers that have been cited by the Obama camp at a relative level, which I think are substantially higher than are likely to occur, indicate that the vast majority of employer-sponsored insurance individuals are likely to continue with that going forward. Let's understand, in this country, we have, on a voluntary basis, employer-sponsored insurance because employers recognize that it is not just as a way to receive the tax subsidy, but it is a way to offer their employees a benefit that they're going to seek and want anyway, and to save them time, to provide it in a pooled arrangement, and that this same interest in providing a benefit, even without the tax subsidy, is going to make employers want to use this as a way to attract skilled employees. Project Hope offers disability benefits and long-term care insurance to me as an employee. It doesn't contribute anything, but it makes available a pooled insurance package and a group rate, and therefore it helps me.
Gail, if I could just ask you to comment. Traditionally, we have seen that take up largely in the large employers, those with 200 employees or more. The take-up in small employers, of course, has been far less, where we see less than 60%.
That is where the problem is, and I don't want to suggest that that problem is going to go away. It is rather that the vast majority of people who have employer-sponsored insurance, particularly other than the 3 or 2 to 9 employee group, which is where the most significant problem has been, and where there has been a secular decline over the last 20 years, that those people will continue. Now, it's really saying that continue with their employer-sponsored insurance. So there is this sense of a quick and large shift of people out of employer-sponsored insurance that I just don't think is likely to be true. It makes no sense for employers who are able in either case to deduct the amount they spend as a legitimate deduction off of their own profits. But we have not had any reason to develop a robust individual market, nor to have other groups other than employers be available because the laws have prevented that, or because the subsidy has been linked only to one place. There's no question that we could have other groups such as student groups or your working association or your religious groups that offer group rates and group insurance, which has not tended to occur because of the tax subsidy. We've had a pretty meager individual market because there have been very few people who have wanted to go that direction because the tax subsidy, they're using after-tax dollars instead of pre-tax dollars.
But also arguably because of the cost. I mean,
well, it is the question about whether or not groups are able to mix risks and therefore offer lower costs. That part you can have other groups form. But the issue is the administrative costs that have traditionally been associated with individual insurance has in part been by the selling and marketing techniques, which will and are already substantially lower because of the use of the internet. I mean, that has had a very big difference. Now, it's very much an age factor. My children, who are in their 30s, when they were buying life insurance, for example, I assumed, would you like to, here's an agent or here's somebody that you can go talk to. And they looked at me like I had at least 3 horns on top of my head. They'd already been on the internet searching out what was available. So there are also strategies that will lower some of the administrative and marketing costs that have traditionally been associated, just as we move to other means for people who are able to access insurance.
David, I wonder if you might want to comment on that, and that is this tension between the question of movement away from the employment-based coverage the entry of women into that market who have not been previously insured. And so one of the questions is, does this in fact expand coverage? I don't dispute at all the question as to whether everyone will move out of employment-based insurance. I don't think they will either. But one of the other questions and challenges we're trying to deal with in terms of women in particular, but people generally, is those who have not been insured and whether or not this opens up an opportunity and the risk of going into essentially a market that is a different market. And I wondered your sense of that in terms of the employment base, but also the questions of portability, people that go from job to job, and the challenges that have been faced by people who have employment-based coverage and can't move easily, and how Senator Obama might confront that issue, which I think Senator McCain has tried to deal with this, with the portability issue.
Yeah. Well, the McCain and Obama camps are going to disagree on the consequences of ending the employer-sponsored insurance tax exemption. You have to ask yourself, looking back 50 years, why it is that employers offer insurance to their employees. They don't offer cars or houses or food. They offer health insurance because it is so advantageous for workers to get health insurance because of the federal tax break. If you take that away, sure, many large employers, Harvard as an example, are going to continue to offer insurance because of the tradition and the commitment that they have to their employees. But at the margin, many companies are going to reconsider, a number of companies. And whether it's 12 million or 22 million or 16 million, there's going to be a substantial loss. If it might be 1 in 10, it might be 1 in 8, but it's a risk that is unnecessary to take to get to full coverage in the United States or to get the kinds of economies that we need. So I think that's the first question, is what risks you take, what risks you're willing to take to achieve your healthcare goals. And I think Senator Obama is not willing to take that risk. In terms of portability, sure, the employer-sponsored insurance has downsides, but one of the problems that has made portability so difficult is that when you lose insurance in the current individual market and in an unregulated individual market, you are at such risk. And if the individual market works, then portability becomes less of a threat to workers who change jobs. And you get the same advantage of portability while you maintain the employer-sponsored pool. I think that the idea that administrative costs are going to be competed away by individuals spontaneously associating with other individuals across state lines and purchasing insurance is a complete unknown. It's betting on a marketplace that has never functioned well, and we have to hope that the internet is going to do away with the underwriting, which is one of the major expenses. So why would an insurance company just spontaneously offer care to someone, insurance to someone without knowing what their pre-existing risks were when they're not required to do so? And they wouldn't be required to do so unless there is a nationwide regulation or all 50 states were to adopt regulations, which they don't right now, requiring that insurance be guaranteed to anyone who applies. So I think that the idea that risk pools, functional risk pools, are going to form spontaneously defies the history of insurance, where adverse selection is just a huge problem.
Let me just, the adverse selection issue, it's a very important issue, and it's come up a couple of times. There are two ways to treat adverse selection or predictably high spending. One of them is being used by the Obama campaign, and one of them is being used by the McCain campaign. The Obama campaign has said, we're not going to allow companies to charge differently to people who have different observable health risks, and they need to be offered health insurance plans, whatever. So it's a guaranteed issue and guaranteed renewability. That is a strategy. If you don't do something to compensate the plans that end up with very different risks, you will either have windfall gains or windfall losses, and you'll encourage bad behavior on the part of the plans. Why should you go get stellar oncologists or infectious disease physicians if you're not going to receive compensation for having unusually sick population? But the other strategy for recognizing that some people are predictably high cost and are sicker is to make allowances on the front end. It's not that it doesn't recognize that there aren't some people who, for whatever reasons, either once they have an occurrence or because of other characteristics about them, are predictably high cost, that you need to make some special arrangements for them. Otherwise, they won't be able to either get coverage at all or only very expensive. And that's a function of these guaranteed access plans, which traditionally have not had a good reputation, the high-risk pools, because traditionally nobody's been willing to subsidize them. But of course, by definition, if you set up a place to take care of predictably high-cost people, you're going to have to subsidize them. That's what you've just defined. And that's really the difference here. So it's not to say that these risk selections aren't very serious problems. It's to indicate there actually are no perfect ways of treating it. You need to compensate one way or another. If you don't, you'll either put burdens on plans leading to bad behavior, which will impact individuals, or you will make it unlikely that people will be able to access insurance. So it's important to recognize these are two different strategies for dealing with the same issues, as is the case with regard to the refundable tax credit, different strategies.
Gail, in that context, one of the things that's not clear from the plan in setting up the guaranteed access plans, which arguably are high-risk plans, whether or not Senator McCain envisions a federal subsidy. I mean, the suggestion is that they would coordinate with the states, but you imagine that federal funds would go into subsidizing essentially that risk pool, as well as state.
Oh, yes.
Okay.
Oh, yeah.
Let's move to benefits for just a moment, because one of the things that Alina has pointed out to us is this question of unique sets of benefits that women in particular are dependent upon. Given the exclusion of a number of benefits from some of the plans as we know them today, again, in the individual market in particular, but generally, David, in the context of Senator Obama looking at the National Health Insurance Exchange, requiring the benefits that are essentially in the federal employees plan, which is a fairly broad plan, do you imagine, or what do you imagine occurring with respect to the large employer plans that are currently prevented from state regulation because of the ERISA laws? Do you imagine essentially requiring of those plans as well a minimum set of benefits to ensure that those that are widely available in the federal employees plan would be widely available as well?
Well, I think that the logic drives you in that direction for the reason that plans that are not offering credible health insurance will have to make a contribution to the sustaining the costs of their employees' health plan and other individuals' health care coverage. The Obama plan has not spoken specifically to ERISA and how the ERISA exemption would be managed under a new arrangement. But he is committed to universal, high-quality, affordable health insurance. And that means that a bare bones plan that's not meaningful, for example, that covers only catastrophic coverage, that doesn't cover drugs, that doesn't cover contraception, that doesn't cover mammograms, that doesn't cover preventive care for women, that doesn't cover vaccination for children, that those plans would not be considered adequate plans from the standpoint of whether an employer was adequately covering their employees.
But again, we haven't talked, or they don't address specifically ERISA, so the history of the ERISA plans essentially being excluded from those kinds of regulations is an open question. Gail, in the context of the moving to a market that allows people to move across state lines, which may open up an opportunity for people to go into a market that is different from, as you suggest, in a state where you only have one or two choices. One of the challenges is that states regulate so radically differently. In some states, there are a variety of mandated benefit laws, which of course some people complain have escalated the cost of care dramatically and made insurance essentially unaffordable. In other cases, the benefits are so minimal as not to be considered adequate for the kinds of things we're concerned about in terms of women's issues, whether it's prenatal care, OBGYN services generally, whatever it happens to be. How do you imagine in a McCain administration looking at that question of what is in fact a minimally acceptable set of benefits? Do you imagine any federal regulation in that respect, or is it a market-driven kind of response in terms of what people look to in terms of seeking coverage?
Let me first go back. Perhaps I'm wrong, but my understanding, just so people here know, I assume the two of you know, actually the Federal Employees Health Care Plan does not have mandated benefits. The OPM,
right.
the Office of Personnel Management, negotiates plans. They need to be reasonable in terms of the benefits that are provided and the premiums that are being charged. But just so people understand, the FEHB, the Federal Employees Health Care Plan, which is invoked so often,
Yes.
especially during campaigns, actually doesn't have mandated benefits like the state of Massachusetts has mandated benefits. And so that is, I mean, it's just an important piece of information.
It is generally a fairly fulsome collection of benefits, but not mandated.
Although it has
negotiated.
health
has
savings
minimum
accounts,
plans.
it had medical savings accounts when they were first there. So
Right.
it has what some people might regard as catastrophic. Those of us who are old enough used to call them major medical plans because for a long time that was what most insurance actually looked like. So that was just people need to understand that. With regard to how plans would be, or how people would be allowed to access them, it is exactly what you have said. That is, people will be able to choose plans in states that do not contain the restrictions or requirements of the state that they're in. It is precisely to allow individuals the ability to have a health care plan that doesn't include mandated benefits for, like in Massachusetts, in vitro fertilization or chiropractic care or podiatric care. Not that any of those are bad things, but to say that if you don't have that, you can't have any individually or other than a ERISA-exempt health insurance plan. But the fact is all states have insurance regulations, and although it may not seem to people living in Massachusetts that other states could care about their residents nearly as much as the government in Massachusetts cares about you, actually most states feel that their insurance commissioners are serious people trying to make sure that their individual residents are protected. They have insurance laws. Individuals who purchase insurance in those states would be protected by the laws of the state in which they purchase. And there would have to be mechanisms in place, some of which have been discussed, but nothing gets discussed much in detail in campaigns, as to how you would have that mechanism go on. It's been interesting to me as I've had this discussion a few times over the past several months, that people have frequently raised the point to me is, why is it that people think only Massachusetts or New York cares about their residents as opposed to people in other parts of the country? They may care differently and have different ways of expressing it, but that really is saying that people ought to be able to choose an insurance package that makes sense and make available information about the kinds of consumer protections, but they ought to be able to choose the plan that suits their needs as opposed to their state legislators.
David, let me go back to you on that topic as well, and then I want to talk about affordability and the tax credit and the subsidies. The reverse of that argument is that essentially there are states that essentially have mandated benefits that make coverage quite costly in those states. As Gail has correctly pointed out, the Federal Employees Health Benefits Plan is not a set of mandated benefits, but it's a fairly fulsome inquiry what the Obama administration would define as being those benefits. Are you concerned, or how do you imagine the issue being confronted if, in fact, there are requirements for benefits that make those coverage plans costly, whether they essentially are in excess of what people would otherwise be able to finance, and that people might choose not to, in fact, have those benefits, whether it's chiropractic or whatever benefits are ultimately defined as being in the plan? So the reverse, as compared to being able to shop, essentially being required to buy a package that someone else has at a federal level defined as being an appropriate level of benefits.
Well, the premise of the Obama plan is to set a floor under the benefits that every American is entitled to and receives. There would certainly be states that would continue to mandate more generous benefits than that. But I think that the premise is that for states that currently don't mandate benefits that are essential, and there are some states that don't mandate vaccination, for example. There are some states without mandated appeals processes for when you're upset about a denied benefit. There are some states that don't mandate mammograms. There are states that have all kinds of permissions to market policies that I think most people think are below what is required and are bad gambles for especially people who are vulnerable to illness. So the idea is to put a floor under that and then leave intact existing state regulations on top of that. Now, these do require costs, but there are many other ways to take costs out of the system, one of which, as I've indicated before, is to make the individual market, which now expends 50%, 30 to 50% of its premium dollars on marketing and underwriting, to make that a market that has costs that are more like 12 to 15%, which is what the large group.
Let's talk about affordability for a moment, then I want to open it up to the audience. Obviously, as was pointed out, one of the issues that women confront is that they are very often low income, very often single parents, essentially have limited resources, in many cases unemployed or in part-time jobs. Gail, with respect to the tax credit, one of the criticisms that has been raised is the size of the tax credit is compared to what we understand to be the cost of an employer-based coverage plan today. Essentially $5,000 for a family against a cost of what's estimated to be about $11,000, $2,500 for the individual. Again, the question in that context is the amount adequate? One of the concerns has been that it will in fact fall short of sufficient coverage. If that's the case, how does Senator McCain anticipate subsidizing or providing resources to essentially allow people to buy into that market? And then David, again, you're asking for mandated coverage irrespective of gender, and again, the question of subsidies to individuals and to small business. And again, the cost of both of these proposals is somewhere in excess of $1 trillion over 10 years is what we're looking at. So we're not looking at a small amount of money. And again, the question is, who does it make it affordable for, and is it adequate? Gail, let me begin with you.
Well, it's actually interesting, the examples that were in the book that I assume your audience has seen, that was sent to me by the center. Because most of those cases were individuals who were working, who could have insurance, but had no help in buying it. And the first woman was 23 and was no longer able to be on her parents' policy, and so she did not have coverage. But most of the examples that were in, I'm sure you didn't do this intentionally, were actually individuals who would be very well helped by the credit because they had insurance that was available. It was not affordable to them, and so they would now have a sizable credit. For people, again, we need to understand, even for low middle income individuals, and you don't get to be a low middle income individual if you're not working, is that most individuals are primarily covering the cost of their health insurance themselves, and what they're receiving when they're receiving it as an employee is the tax subsidy. And the question is, how do we try to make sure that these individuals who may be $30,000, $35,000 a year workers are able to access coverage? And for many, it is to make sure they can access the coverage that's there that they can't afford. Or if they're these young workers who primarily will do quite well, actually, when they have their individual credit to be able to search it out. I mean, if we want to say that for people who are in that middle income range, that $5,000 is not an adequate subsidy, then we really need to rethink what we're doing for the vast majority of people who are in that same income bracket, $40,000, who will receive more subsidy now with this tax credit than they've been receiving traditionally. Because it's not just the people who don't have health insurance that you have to think about. Most of the people in this income category now are primarily paying their own health insurance coverage, receiving some subsidy from the group market and from the tax subsidy. If we are to make for people who don't have employer-sponsored insurance a subsidy that were twice what people who look just like them in terms of their income, but don't have employer-sponsored insurance receive, that would be an incredibly unfair world. So if we think that this $5,000 subsidy...
I'm not sure that I
understand
the argument you're making. Is the argument you're making that because there are individuals who currently receive less than $12,000 a year or some subsidy through their employer, even though we know that group coverage is on average around $11,000 family coverage, that to provide a subsidy that we believe to be less than what will be needed in order to purchase that coverage, that's adequate because there are people who in fact can access coverage on that basis?
No, what I'm saying is that what we need to recognize is that most people who are middle income are spending a substantial portion on health care with a subsidy, not their employer contribution, that's their compensation. That's just their wage given in a funny form. If we think that $5,000, or what is frequently the case now, a couple $1,000 subsidy that people are receiving isn't adequate, we need to think about increasing that subsidy for everybody, not just for the people who are not going to be in group insurance, which is a very different world than what we're talking about. I mean, it really would disrupt the employer-sponsored world in a way. And in fact, of course, is one of the estimates that came out a couple of weeks ago by the Lewin Group is that actually the Obama plan would result in more workers leaving employer-sponsored insurance and going into the public plans than they did for the McCain campaign. We don't have to debate those estimates.
No, but I think one of the questions
but it was for exactly the reason that this notion of what will employers do and how do individuals respond and what kind of a change in the world are you setting up? Is the $5,000 enough to buy an $11,000 policy? Well, no, by definition. The $5,000 won't buy you an $11,000 policy. Will $5,000 buy you most of the way to a good policy? Well, it depends in part on what you're looking for and whether you do it strictly in the individual market or whether you find another group that you can access. Again, most people now who are middle income, who are insured, are spending a significant portion, in addition to the subsidy, to get their health insurance coverage. And people who are receiving a $5,000 subsidy, which is way more than middle income people are receiving now, will have that $5,000. They can add to it. They can look for the best policy they can, that's $5,000 or $6,000 or $7,000 or $8,000. They can look for a group that they can belong to because they're Catholics or they're pipe fitters or they're writers or they're economists or they're lawyers. And to become part of those groups.
Let me ask David to respond, and then I want to talk about raise one other issue, and I want to open it up to the audience. But David, very quickly, in terms of cost, again, going back to the question of what is an adequate subsidy, who is it we are trying to subsidize? I mean, one of the issues is there are a significant number of people who have coverage today, but there are, we know, 45 million people who do not, many of whom are in fact employed in part-time, low-wage work, for whom that amount of money would be excessive in terms of the size of their budget and how much has to go towards health insurance. Again, the question in terms of the defined benefits and the size of the plan that you envision as being adequate, whether in fact it will be priced out of their capacity in terms of purchase and what you envision in terms of subsidy. Again, a different kind of approach, essentially locking in essentially what the defined plan would be.
Well, the goal is to make sure that everyone has high-quality insurance. And that means subsidizing people to the extent that is required to make that possible, and to create efficiencies that would bring within reach adequate insurance. So, we're talking about a federal employees' health benefit package that is in the middle in terms of comprehensiveness, probably. I think $12,000 per person is, actually it's going to be more like $13,000 or $13,600 by the time we get to enacting any kind of health care reform, is what currently is the average premium for a family. And that premium can be made more affordable through the kinds of reforms that Senator Obama is talking about, in addition to the catastrophic reinsurance program that he has been discussing, which will bring down the premiums that are charged to employees. So the question is, how do you get to universal coverage in the most efficient way possible? Senator Obama is committed to a non-refundable tax credit for people whose income is such that they can't afford that package. One of the critical questions.
Let me ask you to finish quickly. That point. Go ahead.
Okay. I thought I'm not sure which point you want me to finish. You must know what's in my head,
I do.
Sheila. You always have.
I do.
So the required subsidy we have estimated to be to lead to annual expenditures on the order of $50 to $65 billion a year. You quoted the $1 trillion figure. That's higher than our estimates. Obviously, under the scenarios that we're talking about, where you've introduced a comprehensive health information technology system, you've augmented the availability of primary care, you've introduced disease management, disease coordination, you've increased the proportion of primary care. Under all these modifications, it's extremely difficult to model with precision.
Really good. I think that's true.
Right.
Yeah.
Yes.
Let me, as I ask people to go to the mics, let me ask you both to respond to one other question, and I'm going to ask folks to line up, and I think there are mics above as well, and I'm going to ask you to identify yourself and ask the question, one question each, and again, in a respectful environment. We have to be kind to David, 4 girls and 1 guy. But as folks are lining up, one final question that I would ask, and that is a question about reproductive health issues. David, what do you imagine to be the priorities in terms of an Obama administration in terms of reproductive health? And Gail, do you imagine Senator McCain supporting any efforts to support access to contraceptives and in either an insurance environment or through public financing? David, quickly, in terms of priorities on reproductive health issues.
Well, Senator Obama is a strong advocate of of contraception, of planning families. He, of course, is in favor of the right to choose. And I think you would find him to be a very strong advocate of women's reproductive rights and of planful approaches to human reproduction.
Okay, Gail?
I'm a board member for the National Campaign to Prevent Teen and Unwanted Pregnancy, which is a group that is chaired by Tom Kane with Belle Sawhill as the president and Sarah Brown, who many of you may know from the IOM, as executive director. And I mention this because it is a group that contains board members who are, some of whom are staunchly pro-life and some of whom are staunchly pro-choice, and recognize that preventing teen, particularly now frequently early 20 unwanted pregnancies, is the better way to avoid the struggles this country has had over abortion for many reasons, and to encourage the well-being of the mother. And as part of this, the group asked if they could meet with the campaign, which I helped facilitate, because I think it was important for both sides to understand that that really is what we want to do, is to prevent teen and unwanted pregnancies, and that there are a variety of ways to make this issue less cataclysmic for our country, which it has been for a long time. Senator McCain does not favor mandated benefits per se as mandated benefits. So requiring that these be a part is not likely. But to make available both information and I don't know whether there certainly hasn't been anything as explicit as discussions of funding or specific. But it is not that there is any interest in precluding this kind of coverage, but because Senator McCain is not in favor of mandated benefits as a strategy to force people to have coverage, but rather to allow people to access health plans that cover the kinds of things that they want to have as that. But for many of this, the question is this really insurance, or are we talking about public health needs that are not really part of the insurance products? That's sort of my view, is something that it's not at all clear to me why this is an insurance question.
And I was really asking it in a much broader context in terms of public support. But let me turn to our questioners. Let me begin on the right, if I might. Your name and your question, please.
Thank you so much for your talk today. I appreciate it and was looking forward to it. In reviewing both McCain and, in reviewing Senator McCain and Senator Obama's health care plan, I was concerned that I didn't see any explicit references to women's health with regard to mental health care. Perhaps I possibly missed it, I don't know. But mental health care is a very overlooked area in our healthcare system in general, particularly in the realm of gender. So I was wondering and hopeful that you can perhaps detail what the senator's position is on mental health care for women. Thank you.
Thanks. David?
Well, you're correct that there's no explicit mention of mental health, but I think Senator Obama would be supportive of the parity requirements that currently exist for mental and physical health care requirements and plans. Women ultimately are, like men, human beings. They have basic mental health care needs, and I think those mental health care needs would be met by the parity requirements that are currently in law.
Yeah. Also, there is not, as was correctly noted, any explicit mention, and it is something you need to at least be somewhat understanding that when it comes to campaign discussions and information, there are many things that are not laid out, not because candidates don't think that they are important, but because there is a limit as to how much they want to be locked into at this stage, as opposed to being able to work within the environment they find themselves when elected, and just because there are so many issues that are being developed. So for both Senator Obama, and I've teased David before of saying, we don't know the pay, we don't know the play, we don't know what the national health plan actually looks like, we don't know what the subsidies are. I mean, that's just, and yet you can make similar comments in terms of some of the specifics that are not part of Senator McCain's plan. Yet this is actually much greater detail than we have typically seen in a campaign where, if you think back in 1992, my favorite was the Pennsylvania race, where the level of discourse was criminals have lawyers, patients should have physicians. That was sort of the level of discourse on healthcare. So,
Thank you.
Up above.
Hi, my name is Shira Epstein. I'm an MPP1 and a current student of Professor Burke. And what we addressed last week in a memo.
Extra points.
We addressed last week in a memo whether we believe the Massachusetts plan was applicable to the nation. And Dr. Blumenthal, a lot of the things that you mentioned, like the Health Insurance Information Network, sounds kind of similar to the Massachusetts Connector, and other aspects sound similar. So my question is twofold. One of the main things that really helped the Massachusetts plan was the public coalition, supporting it. And that included private insurance, business, government, and citizens. And my question is how you and Senator Obama would build that to support a national plan, whether or not it's similar to the Massachusetts plan. And the second question is that one of the drawbacks of that plan was that it didn't address very well sustainability because of rising healthcare insurance costs and healthcare costs in general, and how you guys would address that.
Sure.
David, you get to pick one of those questions. She only gets one, so you can choose the one you get to answer.
She's obviously well prepared, Professor Burke.
That's right.
One of the things that Senator Obama has repeatedly said, and I think it gets back to a point that Gail just made about the specificity of plans. Senator Obama has said multiple times that he wants to develop a consensus around what the plan should look like after he's elected. He understands that building coalitions for this kind of a highly controversial, very expensive, values-laden proposal is critical. And that's why I think in making your choice, you have to look at the values of the candidate as much as you look at the details. And whether someone is committed to universal coverage, whether that's important to them, whether they're committed to affordability, whether that's important to them, because there is, as both Sheila and Gail know, having worked in government, there will be a very complicated negotiation between the administration and the Congress. And what you want to see is what the tripwires are for a candidate going forward. And I think that you're going to be electing someone based in part on your estimate of the ability of that person to build the consensus, to reach out across party lines, and to build a politically sustainable coalition. So I think that was the first question.
Well
and I'm
done.
trying to be as good a student as your other students.
We'll come back if we can. Yes.
Well, actually, I was going to ask the question about cost, so it works out perfectly.
There you go.
My name is Neil. I'm a fourth-year medical student, second-year policy student. I was so excited for this event, I actually drove up from Connecticut, so thank you for the great discussion. So we talked a lot tonight about how the costs of care, on average, disproportionately affect women. And we talked in incredible detail about the issue of covering the uninsured. But as was mentioned, we talked a lot less about the more fundamental issue of dealing with cost inflation. And Dr. Blumenthal, you talked somewhat about the Obama platform in terms of maybe increasing preventive care using health information technology. And I know that Senator McCain has actually proposed quite similar things along those lines. However, most experts agree that neither of those strategies really target the fundamental drivers of cost growth. So my question is, what would either candidate do to limit the use of low-value, high-cost technologies, and, for example, maybe do something about the 30% C-section rate that we heard about earlier?
Gail, you want to begin?
Well, I had at least referenced, but I can tell you a little more in terms of how to try to change the delivery system. As you indicated, there are areas of commonality in terms of focus on prevention and chronic disease management, information technology also, which I didn't mention. Those are important, but there's some question as to how quickly, at least, though, the costs will decline moving in those directions. Changing reimbursement so we reward the kind of behavior we want to see from physicians is very important, and institutions is very important. Medicare is a clear indication that when you reward for more and more complex, don't be surprised if that's what you get. The changing reimbursement system so you reward the kind of behavior you want, which is more efficient, high quality, patient-centered care, means a lot of change in the Medicare program, and with the expectation, as frequently happens, that private payers in some cases will lead, but in many cases will follow. Understanding more about value and pricing, understanding more about what works when, is an area of particular interest to me. It is also not a quick win, but it is an important part of learning how to have practices work better, and it means investing in information about what works, and then allowing the kinds of reimbursement systems that will reward that. One of the concerns that I have, and we will see, how this all plays out, is that having government specify the reimbursement has not been a way to get much flexibility. I'm personally very impressed with the notion of value-based insurance that has been raised, Mike Chernow and Mark Fender, and others have talked about, where you vary co-insurance and or some of the reimbursement according to the likely value. But think back about what the government did when it protected seniors under Medigap. It put in legislative language the 10 policies that seniors could buy. And when you had things like having variable co-insurance rate, you'd have to change the friggin' law. I mean, those are the kinds of regulatory burdens that you really need to watch out for in an area that is still evolving as much as our interest in comparative clinical effectiveness. And then when you have information about that, having reimbursement that encourages what works. We're not likely to be a country that says thou shall not or thou only can in terms of using new technologies. But we certainly can do a much better job of spending smarter and treating better if we get better information and allow the kind of reimbursement that would support what we have. We have a perfect indication now how responsive clinicians and institutions can be to bad economic incentives. We see it in our healthcare system all the time.
David?
So I think in broad strokes, the McCain and Obama campaigns are very similar in terms of the system reforms they want to advance. But I think one of the critical differences is in the commitment to disseminating information technology. And let me tell you a little story about what my practice is like. And Paula practices in the same Partners Health system that I do. So in order to order a MRI or a CAT scan, I have to use a system called radiology order entry. That system works because I have an electronic record. I have to fill out a pre-specified set of indications for that MRI. And if the patient doesn't meet those specifications, I will literally get a red light that tells me it's not an indicated test. Now, I can still order the test, but if I keep doing it, eventually somebody in a white coat is going to come down and say, you're an outlier in terms of what you're ordering. And that combination of what Gail has advocated, I think, very positively, which is good information brought to the point of decision through information technology, is going to be critical to what's called bending the curve with the escalation of healthcare costs. Now, the Partners Health system, through using that just-in-time electronic delivery of guidelines, not coercive, but instructive, has empowered me to be a better physician. And I think with the right investment, could empower physicians across the United States. But you have to make the investment. I don't believe that this country is going to get to 60, 70, 80% adoption of electronic health records without a major federal investment. We're at 17% right now, going up at a few percent a year. It's going to be 2030 before we get universal electronic records in the hospital or in the physician office. And that's the empowering technology. It's not sufficient. It has to be combined with comparative effectiveness research that improves our knowledge of what's indicated. But I don't see in this society how we're going to get to cost containment without that kind of support.
Yes, young lady.
My name is Denise Diaz, and I'm a first-year Master's in Public Policy student. And my question kind of steps back from broad details of policy, but focuses more on specific policy. And specifically the a vaccine that became mandatory for immigrants as of July 1st, 2008, the HP vaccine, which became mandatory for immigrants. And it's expected to affect about 130,000 females. And I would just like to know if either campaign or either one of you have any specific perspectives on this issue. Because it's not mandatory for females in the United States, but it's mandatory for immigrants. And it's been really highly criticized because of the cost burden, since the shot is about $162, and 3 shots are required.
David, Gail?
Well, the campaign has no specific policy on that issue. So anything I say about this would be individual and probably not very well thought out. But I have a daughter, and she is eligible for that vaccine, and I would want her to have it. I'd want her to have a choice about whether to get it, and to make that decision with me or not with me. She's old enough to make it by herself, but I wish she would have it, and I'd want it to be affordable for her. And I think that's an elementary public health initiative at this point in time. It is a complicated issue because of the values, the controversial values of this country around women's reproductive rights. But I think that that's a misplaced controversy, and I'm confident that Senator Obama would agree with that.
There is no position by the campaign. I actually just heard about this issue personally in the last couple of days. There was some information that was disseminated. I honestly don't know why the law is put in place, whether it is who it is that it's supposedly protecting. So I was surprised to hear about it, and I don't have any insights as to what the senator position would take on this.
Hi, my name is Mike Miller, and I noticed that all of the panelists work for nonprofit organizations. So I'm wondering about Senator McCain's position, his proposal. Eliminating the tax deductibility of health benefits really wouldn't affect anybody who works in government or nonprofit organizations. Whether the senator's plan would envision some kind of like payment in lieu of taxes like local governments have to make that the treatment of health benefits equal between nonprofit and for-profit companies.
That's actually, you raise a very good point because
do I get extra credit in your class if I take it?
No, it's to make sure that you understand why, in many cases, the for-profit, not-for-profit distinction is important. In this particular case, the employer is treated exactly the same. So it doesn't matter, because the employer is able to deduct the wages however they're given. In one case, it's a for-profit, or the other a not-for-profit. The only change that Senator McCain is proposing is how employees, like me, would be affected. And that is, now I'm able to not count my employer contribution as part of my taxable income. I know my contribution. I actually don't know exactly what Project Hope contributes on my behalf, but I would learn soon enough because I would have to count it as my taxable income. So in this particular instance, the employer continues exactly as the employer's been doing. So whatever for-profit, not-for-profit status, it doesn't matter. It's the employees that will be affected because now they'll count that employer contribution. It'll be a wage like any other part of their wage, but I will get, as part of a family, $5,000, which will more than compensate the additional taxes that I would pay and put the rest in my HSA. Just
So I can clarify, because this is something that I guess
No,
I didn't understand,
Yes.
is that the employer's payment for your health insurance, not your own premium
Right.
payment, but the employer's own payment, they would not have to pay tax on that as some kind of...
They never do.
No, I understand they haven't in the past, but under the plan, they would have to pay tax on it, but under the senator's proposal, you would have to pay tax on that as part of your income.
Right.
Yes.
But the employer is not changed in the way the
business
employer...
expense.
It's a business expense no matter
But
whether
but
it's.
nonprofits don't get a business expense
But it
deduction for
doesn't-
that.
But it doesn't matter.
But it doesn't matter.
Okay.
It's
Yeah.
the employee.
It's the employee that is changed in terms of behavior. But there are people who think that the employer will somehow lose something that they have now that they won't have in the future, and the answer is
Yes,
no. They're
no, it
just,
doesn't count.
it's a business expense, no matter whether they give you a fringe benefit or whether they give you a cash wage.
Please join me in thanking our speakers. And also our terrific presentation by Alina. And all of that material is over to the left, as are the materials from Paula's folks. So my thanks to the center, my thanks to the Wiener Center, my thanks to the Institute of Politics, and my thanks to my two friends and colleagues. Thank you all very much.